Welcome and thank you for joining us today for this webinar, introducing NPIC, the National Private Insurance Claims Data for Research. My name is Jane Brookstein and I'm the Director of Membership for Academy Health. I'll start with walking you through the technical aspects of our webinar. If you are having trouble connecting to the audio portion of the conference, click the phone icon at the top center of your screen. A box will pop up and ask you to enter your telephone number. If you prefer to dial directly into the conference, the phone number and access code can also be found by clicking on the phone icon. If you have technical difficulties at any point during the meeting, you can access live technical assistance by calling the number listed in the technical assistance box on the bottom left corner of your screen. To submit a question, click in the dialog box below the Q&A window on the left side of your screen. Type your question and click the send button. We will try and respond to as many questions as possible during the time allotted. This is intended to be an interactive forum, so we encourage you to submit your questions throughout the presentation. The last portion of the webinar will focus on questions and answers based on the written questions you submit. We'll do our very best to address as many of them as possible following the presentation. To ensure your questions get answered, please submit them as early as you can. Now, I'd like to introduce you to Academy Health's President and CEO, Lisa Simpson.
Thank you, Jane, and welcome everyone to our webinar this afternoon. We are delighted that you could join us today. First, I just want to take a moment to tell you about Academy Health. We are the professional society for health services research and health policy analysis, and those who produce research and use research. And we seek to improve health and healthcare by generating new knowledge and moving knowledge into action. This is one example of the many online training opportunities on methods for health services research and data and various other timely topics that we offer. I hope you will visit Academy Health's website at www.academyhealth.org to learn more about the field of health services research, our productive and very smart members, and all the training resources we have available to you. And I hope you will consider joining as a member if you are not already one. First, let me tell you about the learning objectives of this session. We were simply delighted to have the opportunity to work with this new initiative and with Robin in putting this together. And I think you will find this learning about this new data resource extremely valuable. Participants in this session will receive an overview of the National Private Insurance Claims Database for Research, or NPIC database, a national collection of over 13 billion, that's with a B, billed healthcare services from 2002 to the present, reflecting the cost of care and utilization experience of over 125 million insured Americans. Participants in the webinar will learn about the NPIC database and its application to health services research, how it was developed, how it differs from other sources of data that you may be considering to use to answer your research questions on healthcare utilization and spending, and how it will be made available for research. Now it is my pleasure to introduce our first speaker, Robin Gelburd, the President of Fair Health. Many thanks for being here today. I will now turn things over to you, Robin.
Thank you, Lisa, for that introduction. I am delighted to be participating in this webinar, which will provide you with an exciting window into our new research platform called FH NPIC, a National Private Insurance Claims Database. Joining me for this webinar are Ray Agostinelli, the Chief Information Officer for Fair Health, Professor Sean Nicholson from the Department of Policy Analysis and Management at Cornell University. He also serves as the Research Director of the Upstate Health Research Network, a consortium of 8 institutions that serves as the research arm of Fair Health. Dr. Scott Braithwaite, an Associate Professor of Medicine at the New York University School of Medicine, who also serves as the Chair of our Scientific Advisory Board, a national body of leading economists, statisticians, health systems researchers, and the like that advise Fair Health Management and Board on a wide range of issues involving our data methodologies and algorithms, research policies and protocols, and consumer website. We are also privileged to have Dr. Cary Gross, a professor of medicine at the Yale School of Medicine, joining us today. Cary is another member of our Scientific Advisory Board and has provided valuable feedback to Fair Health on the development and design of this research program. During this webinar, we will address the unique origins and mission of Fair Health, provide you with an overview of the database, describe our current suite of data products that support industry stakeholders, share with you the key aspects of our state-of-the-art technology environment, detail the special features of our data contribution program, provide a high-level window into our data auditing and validation program that supports the integrity of the database, describe the types of data that will be available for licensing through the research program, identify the types of research that could be supported by the FH NPIC database, and finally walk you through the user-friendly application process for licensing data. As you probably know, Fair Health was created as a result of an investigation brought by then Attorney General Andrew Cuomo. The Attorney General was looking into certain practices involving out-of-network reimbursement. In the course of the investigation, the Attorney General determined that there was an impermissible conflict of interest in the way in which out-of-network reimbursement was being calculated. The case was ultimately settled by all of the parties in 2009 for the collective sum of $95 million. The settlement featured certain key elements. First, it provided for the creation of a new, independent, not-for-profit organization. That new entity is Fair Health. We were established in October 2009. Next, it required Fair Health to create a robust database and enhanced data products to make available to the insurance industry in order to further the fair and transparent adjudication of out-of-network claims. And third, Fair Health was tasked with creating a free web-based portal which would allow consumers to obtain information about the cost of procedures and services they may access out-of-network in the specific geographic region where the procedures would occur. Finally, and significantly, we were mandated to develop a research platform to support public policy, health systems, and health economics research. It should be noted that the settlement agreement required that Fair Health integrate the talents and expertise of academic researchers into the development of a new database. Accordingly, we partnered with a talented team of researchers who are known as the Upstate Health Research Network, the consortium I alluded to earlier, of which Sean Nicholson is the research director. In addition to working with the UHRN, we work with a national board of scientific leaders, including behavioral economics, economists, healthcare economists, health policy experts, and the like, who further inform the work we do. As noted earlier, Scott Braithwaite is the chair of that body, and Cary Gross is one of its members. Finally, one key point should be emphasized. Even though the New York Attorney General was focused on activities within New York when he launched his investigation into the healthcare industry, the settlement agreement resulted in a national remedy. That is, once Fair Health was prepared to stand up a new enhanced database under the terms of the agreement, Ingenix Corporation, which previously released benchmark data for the adjudication of out-of-network claims to insurers across the country, was required to stand down. The exit of Ingenix from the market created a national void that was very soon filled by Fair Health. We spent 2010 establishing our state-of-the-art technology environment, enhancing the database, refining the data products, and developing the consumer website. We went live in January 2011, beginning our release of data modules, which I will describe shortly, and launching the first of 3 stages of the consumer website. The first stage of the website involved the launch of our educational content and consumer resources. The second stage involved the launch of the dental cost lookup tool in April 2011, and in August 2011 we launched the final stage of the website, which featured our medical cost lookup tool. I'm proud to say that our website was recently honored at the White House Summit on Smart Disclosure. We were recognized as providing smart, actionable data to consumers to facilitate healthcare decision-making. From the time we went live in January 2011 until today, we have achieved extraordinary growth and, more importantly, acceptance in the healthcare industry. We have entered into contracts with nearly 500 different customers nationwide, consisting of insurers, TPAs, bill review companies, employers, unions, and consultants, who collectively insure or administer insurance plans covering over 177 million covered lives. While the original New York investigation into Ingenix and the resulting settlement largely focused on the adjudication of out-of-network claims, our data products and consumer tools have had a much broader reach. In addition to supporting out-of-network reimbursement, our tools and products have become increasingly valuable to the management of consumer-directed health plans and the sound design of ACOs and bundled payments. Fair Health data also serves as a strategic tool to help inform the negotiation of network panels and an important assist to human resource and health benefits personnel who have begun to see the concrete impact and advantages of shaping a growing generation of informed consumers. Our data and consumer content have also attracted the attention of a number of states as well as the federal government. We have a number of conversations underway with various states about how our data can support their UCR fee schedules, workers' comp and auto liability programs, anti-fraud efforts, and reform initiatives. We have also had an ongoing dialogue with the federal government about how Fair Health can help inform consumer fact labels, medical reimbursement data centers, and essential benefit design under the federal reform bill, a fruitful dialogue that we welcome. It has been heartening to see how we become such a vital part of the national conversation on cost transparency and data integrity. As we have moved forward with developing a robust and transparent database and innovative website, product offerings, and research platform, we have been fortunate to have had access to a wide network of stakeholders. We've put out a welcome mat to all such stakeholders to obtain different points of view and suggestions about ways in which we can enrich the products, further the integrity of the database, enhance the website, and design a research program that puts valuable data in the hands of researchers. It has become apparent that our agnostic, neutral position in the marketplace renders us perfectly poised to field competing points of view and valuable suggestions from key constituent groups. Indeed, we have viewed the creation of Fair Health following the New York investigation as a rich opportunity to enhance the product modules previously distributed, to develop new data products that serve a broader array of the market, to create transparency and innovative educational tools for consumers, and to contribute in a productive way to research and policymaking in this time of rapid change and reform. What makes Fair Health and Fair Health data unique? It should be noted that we house the largest and most diverse private claims data collection in the country under the roof of an independent, not-for-profit institution. We have nearly 80 contributors nationwide who contribute data to our repository, and that number continues to grow as new contributors approach us seeking to be part of our contribution program. The data contributed covers over 125 million covered lives. At the conclusion of March 2012, we had approximately 14 billion, which had grew from the 13 billion we had previously posted because it continually grows as the data gets refreshed and updated on a rolling basis. That data is for the period 2002 to the present. The data are organized into 491 distinct geozips in order to provide a rich, granular geographic tapestry to enable analysis and market use. A geozip tends to track with the first 3 digits of a zip code. We incorporate academic research directly into our work and data products, thus the Fair Health database, together with its underlying methodologies and algorithms, reflects the talents and expertise of the Upstate Health Research Network as well as our National Scientific Advisory Board. We also employ a robust auditing and validation program to ensure that the data is complete and representative. Once we analyze the data, we organize it into 7 different subject matter modules or flavors, if you will. The modules we distribute include a medical surgical module, which includes CPT codes for medical, surgical, radiology, laboratory, and pathology procedures, as well as E&M codes. An allowed medical module, which includes fees allowed by plans rather than fees charged by providers. The data is available by plan types such as HMO, PPO, and an aggregate value. A dental module, which includes CDT codes. An inpatient facility module, which includes codes for services performed in a hospital inpatient setting. An outpatient facility module, which includes CPT codes for services performed in a hospital outpatient setting. A HCPCS module, which includes Level 2 HCPCS codes for products, supplies, and services, not included in CPT codes such as ambulance services, durable medical equipment, prosthetics, orthotics, and supplies when used outside a physician's office. And an anesthesia module, which includes CPT Category 1 codes, anesthesia codes, and surgical procedure codes. All of these modules are based on our private claims data collection, except for the inpatient and outpatient modules, which draw from CMS MedPAR and OPSAF data, respectively. At this time, I would like to pass the virtual speakers podium to Ray Agostinelli, the Fair Health Chief Information Officer. Ray will discuss our contribution program, auditing and validation practices, and the types of data we will be offering to the research community pursuant to our research program.
Thank you very much, Robin. I'm going to use the next segment here to provide an overview of the processes and the technologies that support our data repository and wrap up with a few simple visualizations of the data that Sean and Cary will then expand upon. First, to the data contribution program. Data is contributed to Fair Health from approximately 80 commercial payers nationwide. We receive claims across the spectrum of healthcare services, including medical surgical procedures, dental, anesthesia, and HICPICs. Now, in order to participate in the program, contributors have to meet a number of requirements and formally certify their adherence to those requirements. For example, the claims must always include the non-discounted fee-for-service billed by the provider to the payer, as well as the location of the service. Under the terms of the contribution program, payers must also attest to the fact that the submitted data represents the full set of claims for the submission period. So payers are not permitted to exclude claims or otherwise edit their submissions. Contributors submit data on an ongoing rolling basis, some monthly, some quarterly, or every 6 months. And this results in a continuously expanding underlying repository from which our data products are produced. It is both the underlying data as well as the data product modules that Robin just listed that will become available to researchers under the auspices of the NPIC program. Now to the data itself. When submitting data, contributors are required to include some data fields, others are optional. And among the fields that must be submitted, and therefore are always present in the underlying claims, are the procedure code, the zip location where the procedure was performed, the dates of service, the non-discounted fee for service billed by the provider, units, anesthesia time, and modifiers, as well as a few other fields. The fields that are optional, and thus are not always fully represented in the underlying claims, are the claim ID, the claim type, provider information such as the NPI, the tax ID, or the provider address information, patient information such as date of birth and gender is also optional, diagnostic codes as well. There's about 20 additional optional fields in the contribution form program. Now, consequently, for any given set of underlying claims data that a researcher might work with, there will be a subset of fields that are always represented and a subset of fields that will be present a certain percentage of the time. Turning now to data validation. Upon our receipt, all data are subjected to a rigorous validation process to ensure the highest quality throughout. For example, dates of service must be within expected ranges for each submission. Since the geographic component is essential to the data, we do validate that the service zip code is a location at which services can be performed and not a billing location, such as a P.O. box. We check that modifiers are valid for procedure codes, that charges or units are not negative values, and other edits of that sort. Of course, all required fields must be present and valid as well. The validation edits are really the first and most obvious step in a program of continuous quality improvement that Fair Health has committed itself to. Our internal quality team, which includes credentialed, statistical, clinical, and technical personnel supported by data analysts and others, continually evaluates and refines a set of tools and techniques that we use to obtain a window into the data at all stages of the process, from the initial receipt through to the product creation stage. We do maintain a close relationship with all of our data contributors. If we find that the rejection rates due to validation exceed certain thresholds, we work with the contributor to determine the source of the problem, and we solve the problem. To talk a little bit about the technology infrastructure, it is a state-of-the-art infrastructure which is very stable, and in fact it's put to the test every day as the enormous volumes of data that we manage pass through the various stages of the system. It's compliant with all HIPAA and other regulatory requirements. We also have a robust business continuity and disaster recovery program in place at a third-party location. And we are capable of distributing data in a variety of formats, and this minimizes the work involved with loading the data into the various technical systems, many of which are legacy systems among the disparate IT departments in our base of over 500 customers. And we aspire to and will bring that same flexibility to bear in terms of distributing our research products. Okay, let's talk for a moment here about what specifically will be available under the research program. We will have two fundamental offerings. The first is our core product modules, which Robin alluded to in her comments. The product is available in both standard and custom versions, and a custom version may involve computation of rates using an alternative geographic aggregation, for example. Likewise, a custom version may involve selecting a certain set of clinical codes to support a particular study. For example, a researcher may be interested in pediatric dental codes, cardiology-related codes, or codes pertaining to the care of type 2 diabetes. The product includes provider charges for each procedure, arrayed by percentile, as calculated within each geographic region. And as we noted previously, the fundamental geographic unit in these data is the geozip, which is roughly equivalent to the first 3 digits of the zip code. In the product, the mean, median, and mode are also supplied. The benchmark product that I've been discussing here is based on actual values. But it is worth noting that in our current product creation methodology, values in some situations are derived, namely those where there are insufficient data for a given procedure within a given geographic region. And these core product modules that I've been discussing are available to researchers today. So if you are interested in these products, you can get in touch with us through a simple web-based form that is resident on our website, and Robin will discuss that briefly at the end of the webinar. The second offering for researchers, and this will become available in the summer, includes the actual underlying claims from the data repository. And so as we noted previously, the repository includes medical and dental claims from 2002 to the present, and it's continuously growing. We'll be offering the underlying claims in the form of a standard analytic file, which will de-identify claims according to HIPAA regulations and other established standards. The de-identification will require encrypting or transforming some fields, such as limiting dates to years, encrypting claim IDs, and the like. The data will include most of the fields from the underlying claims, both required and optional, that we receive from contributors, including the date and location of service, the procedure code, the charge, the units, etc. Our philosophy in this regard is essentially give what data we have. We won't have every data element filled on every claim, but if it's there, we do want to make it available. Now, given that we currently have 14 billion billed procedures in the repository, if a certain data element appears in only a portion of the claims, that still does provide a very broad window into the marketplace. To minimize any data cleaning required by researchers, we will apply the basic validation edits as I described earlier to claims before including them in the standard analytic file. So also, finally on this point, we will be making available a full data dictionary of all the elements included in the NPIC datasets as we get closer to the formal launch of the program later this year, and we'll include in that a reflection of the percent at which the optional fields are filled. So you'll have a very good sense for what is and what is not included in the data. Okay, on the next 4 slides, what I'd like to do is just show some simple visualizations of the data, this by way of preparing the palette for more in-depth examples to come. These are appetizers, if you will, so I won't spend a lot of time on them, but I'll just go through a couple of very kind of high-level examples of visualizations of the data. On this particular graph, we see charge values for a single procedure code plotted across percentiles for various geozips. And so we can see at a glance here that the light blue line pertaining to the 100 geozip, which pertains to Manhattan, sits at the top of the charge spectrum for this particular procedure, which is not particularly surprising. On the next slide, we have a histogram, and this histogram is a simple frequency distribution of charges. Again, it's one procedure code across geozips, revealing a roughly normal curve with most charges in the middle of the range. Okay, moving on. Here we have a scatter plot that correlates charges from 2 subsequent product releases. So what we're doing here is comparing percentile charges for one procedure in one geozip 6 months apart. And we see a high degree of correlation for the most part particularly at the high end of the charge distribution. The purple circles here are the 95th percentile, with a little more decrease in charge at the lower percentiles. The blue circles are the 80th percentile in the upper left of the chart. So overall, this plot would tend to confirm a fairly high level of consistency over time for this particular procedure in this particular geographic location. Finally, we have a simple line graph of mean charges for a series of related procedures, in this case dental procedures, useful perhaps for an at-a-glance view of charges across a product group for someone familiar with the codes in that group. I will now pass the virtual baton to Sean Nicholson. As we noted previously, he is the research director for the Upstate Health Research Network. He's intimately familiar with the NPIC database. Sean and his team have been working on the data since the creation of Fair Health, and they continue to play a very valuable role in maintaining the integrity of the repository. Sean?
Thanks for the introduction, Ray. What I'd like to do is take a few minutes to describe, from my perspective as the research director of the UHRN, what I think some of the attributes of the NPIC data set are. And I've been working with it along with my team for a couple of years, and I think it's going to be a valuable addition to health services research and health economics research. So let me begin with some of the characteristics that I think are going to make it attractive to some projects for health economists and health services researchers. So first of all, a lot of work has been done to examine how Medicare patients are treated and how the quantity and the cost and the quality of treatment vary across markets for Medicare patients. But much less is known regarding how privately insured patients are treated, even though they represent the majority of the patients in the U.S. And the NPIC is going to help address this by focusing on the privately insured market. Second, the NPIC contains an enormous number of claims, as Robin and Ray have mentioned, covering a total of 125 million people. The third, I think, positive attribute is that the claims go back in time to 2002. So this is going to allow somebody to examine how medical care and prices have changed over a long time period. Fourth, there's great geographic breadth. So the NPIC has claims from every 3-digit zip code in every state of the U.S. And fifth, the NPIC has information not only on what providers charge, but often how much the provider is paid by the health insured and the patient, so the actual transaction amount that economists often prefer. And then finally, physicians are assigned a consistent ID, so if you're interested, you can follow physicians over time in the data set. So I think the NPIC is well suited to address a number of different types of questions, and I'll elaborate on some of those in the next couple of slides. So one application is to use the NPIC to look at the effect of policies that are occurring in some states but not others. So the sort of difference in differences analysis that's commonly used. So, for example, some states might have placed caps on pain and suffering malpractice awards, and this should reduce malpractice premiums and defensive medicine, at least that's the hypothesis, in states that do implement those reforms. With the NPIC, you can use the data set to see if the quantity of certain medical services and the prices of those services falls over time in states that implement caps versus states that don't. Similarly, you could look at, for example, if a state implements a fee schedule change for auto liability cases, does the quantity of services provided and the generosity of those services increase or decrease following the policy change? You can also use the NPIC to measure differences across healthcare markets in the use of diagnostic services, so, for example, mammograms. And then these differences in the use of diagnostic services could be linked with some already existing data on quality or outcomes that are also measured at the market level. So, for example, from the SEER data set. Some more examples on the next slide. You can use the NPIC data to also look at differences in treatment protocols across the country. So are there different treatments for treating high blood pressure or treating or diagnosing breast cancer based on locale or based on geographic market? And you can also, given the geographic breadth that I mentioned earlier, you could use the NPIC sort of as a epidemiological heat map. So since the data are being collected quarter by quarter, you could look to see if there are sharp increases in certain diseases Or more specifically, what you'd be able to see is treatment of certain diseases. So are there increases in the treatment of certain diseases that might inform public health programs or changes in treatment protocols or changes in medical school curricula? You can also see if decreases in the treatment of certain conditions are correlated with specific public health initiatives. So is there reduced treatment for lung cancer in areas where there's been a concerted effort to reduce smoking? In general, the NPIC can be used to measure differences across markets in spending, and then to determine whether spending differences are driven primarily by differences in the quantity of services provided or differences in the prices of the services provided. And these spending differences can then be correlated with outcomes differences that are reported from other data sources such as the Medicare Hospital Compare website or in certain states, physician report cards. The NPIC can also be used to document physician payment differences across markets and to examine whether those differences are correlated with differences in the size or the concentration of physician groups and or differences in health insurer market power across those different markets. So as I mentioned earlier, the NPIC can be used to do difference in differences analysis of policies. And what I'm showing here is some work from one of the UHR researchers where he used claims data to see whether physician payments, and here this is the allowed amount, not the charge, whether physician payments fell in South Carolina after they instituted malpractice reform in 2002 relative to North Carolina where they did not institute reform. And here he's focusing on a common radiology procedure for prenatal visits. And he did find that in South Carolina the payments did fall, which is consistent with the physicians passing along malpractice costs and also passing along malpractice cost savings from reform to the payers. So I've also been using with some of my colleagues the NPIC data to examine why some markets have experienced large and other markets small changes in physician-allowed payments over time. And then more generally, we're looking at whether private fees respond to changes in Medicare fees across different CPT codes and across different three-digit geozips. And here, we're breaking Medicare regions into those that experience small, medium-sized, and large changes in private payments between 2003 and 2009. And sometimes, sort of related to one of the figures that Ray showed you earlier, researchers might be more interested in looking within a market at whether physician charges differ between physicians in that market or geographic area. And then if they do differ, why do they differ? So in this figure, you can see a distribution or histogram of physician charges for a laparoscopic cholecystectomy, removal of the gallbladder, in the Long Island market. And so what you can see is that most of the physicians are reporting charges that are fairly tightly clustered to the left or the low charge side of the figure. But there are these clusters of higher physician charges to the right of the figure. Now, so certainly the NPIC database has a number of strengths that I've tried to outline. It also has some limitations that I think it's useful to understand so that you can identify whether it's the particular good match for your research project. Probably the biggest limitation is that it's difficult to follow the same patient over time. So you can't stitch together a patient's complete episode of care for a particular chronic health problem that they might have. Or you can't necessarily link an outcome today from one claim to the care that a patient either did or didn't get in a prior time period. Another limitation is that you're not always going to know how many covered lives generate the claims that you're observing. So, for example, you might observe that patients in Texas received 10 million office visits in 2010, but you might not know how many enrollees were covered by the private health insurers in Texas that actually submitted those claims to Fair Health. So you might not be able to determine the average number of office visits per person per year. Now, the reason I'm saying might is that in some instances, researchers might be able to get the number of covered lives from, for example, the Department of Insurance in a particular state, and then those data could be merged into Fair Health to get true utilization figures or utilization rate figures. Finally, there's limited information on patient outcomes in the claims data. So, for example, you would not be able to tell what a diabetic's HbA1c test value was. Was it below 7 or not? But you could observe whether the test was ordered. Now, in some instances, because the ICD-9 field, you may be able to make some inferences about outcomes using the ICD-9 data. So I'm now going to turn the baton over to Scott Braithwaite, and as Robin mentioned, Scott's at the NYU School of Medicine and is the chair of the Scientific Advisory Board of Fair Health, and he's going to be able to describe how the members of the Scientific Advisory Board help to shape the priorities and the design of the Fair Health Research Program. Scott?
Thank you so much, John. It's a pleasure to take the virtual baton. I am the chair of the Fair Health Scientific Advisory Board, and in the next 5 minutes, I'm going to give a portrait of the Scientific Advisory Board, along with discussing some of its processes and some of its goals, some of its recommendations, and also its relationship with the Fair Health Board. So the Scientific Advisory Board is a national body of academic researchers comprised of market economists, behavioral economists, health systems researchers, and health policy experts. And we are tasked with 3 main areas of focus. The first was to provide input on database methodologies, algorithms, and quality control. Second, to help frame and identify needs that are relevant for the consumer website survey. And then third, to assist with the design and establishment of priorities associated with launch of the Fair Health NPIC database. There are many members of the Fair Health Scientific Advisory Board, and I won't describe each member in detail, but what I can tell you is that there's a tremendous institutional diversity. Looking at the list, in addition to people from New York universities, you also have investigators from other institutions, such as the University of Pittsburgh, Yale, and Harvard, and the University of Michigan. In addition, there's a great amount of geographic diversity among the investigators in the Scientific Advisory Board. As you can see, we have people from the West Coast as well as the East Coast as well as the Midwest. In the fall of 2011, we began detailed discussions regarding the shape of the program, how the Scientific Advisory Board should be constituted and should function. We identified key issues associated with the launch of this research program, and it was a particular challenge because of the scope that has been described by Robin and others. And we established the necessary subcommittees and processes to work as a group to develop key recommendations for the Fair Health Board and management. What are some of these recommendations? Well, first, it's very important that the research offering of Fair Health should include existing data modules as well as underlying raw claims data. So the underlying data should reflect a certain level of cleaning to enhance the validity of claims and to reduce unnecessary work burden for investigators. So, for example, ensuring the valid zip code and procedure code quality controlled measures that were described earlier by Ray. The program should feature streamlined, simple data use agreements that are not unduly burdensome for investigators. And then, continuing on that theme, the program should be user-friendly. There should be multiple options for technical assistance. Frequently asked questions should be readily available. User guides should be readily available and easily interpreted. And there should be access to papers that cite NPIC data so investigators that are considering using the database can get real examples of what it has been used for in successful publications. And again, it's very helpful that the Fair Health Scientific Advisory Board is made up of investigators who are performing and publishing research, so they're well acquainted with the barriers that can go along with accessing a new database and figuring out how to use it. Other Scientific Advisory Board recommendations are that the program should offer a quick turnaround time for delivery of data, pricing should be reasonable and tailored appropriately to the category of applicant. So, for example, a graduate student should not be paying an extremely large amount, say, for example, that another user would pay. The program design should allow for automatic updates at a reasonable price, and it should feature flexible, easy amendment processes in order to address expanded projects and uses, because not every use by an investigator is imagined at the time that the database is initially accessed. Scientific Advisory Board program recommendations have by and large been adopted by the Fair Health Board meeting. So we have a process by which we can present all of our recommendations and have them discussed very comprehensively at the Fair Health Board meeting. Key recommendations have been integrated into the NPIC program design and have been reflected in what you've heard today, and the Scientific Advisory Board will continue to provide input following program rollouts to help ensure user-friendly characteristics of the program and to continue enhancing the research environment. And all of us will be talking to you about what are some of the possible research questions that you can make use of this unique data source for. And I'm going to give a couple of questions also. So for example, you could ask very interesting questions like, do out-of-network charges vary with the density of networks in a region? With the market share of particular networks in a region? With the density of providers in the region, or the market share of particular providers in the region? You can look at differences or gradients between in-work and out-of-network provider density, and you can stratify by specialty. And finally, you can look to see the extent to which charges or differences between in and out-of-network charges vary with urgency of procedure or other characteristics of the procedures which you think ideally should vary very little, because if they did vary little, they would constitute major barriers to accessing care. Now, I hope that this gave you a helpful overview of the Scientific Advisory Board, and now I'm going to turn the virtual baton over to Cary Gross, who is an outstanding researcher and is a full professor of medicine at the Yale School of Medicine.
Well, thank you, Scott. I appreciate the outstanding researcher kudos. I'm actually still an associate professor, but with that endorsement of being outstanding, hopefully that'll help to push me over to full professor. So I really appreciate the opportunity to speak to this group. As a member of the Scientific Advisory Board, my role on this webinar presentation today is to present the perspective of a researcher. I'm a general internist. The major focus of my work is on studying the care of patients with cancer and studying cancer screening. And I've largely been using publicly available databases such as Medicare over the past decade. And I've long been frustrated by a lack of access to similar data from private payers. So as a result, it's been very gratifying for me to be able to help to contribute to the design of this new resource that will help to allow health economists and health services researchers to gain access to billions of healthcare claims for medical and dental services. So as a member of the advisory board, I would like to echo Scott's comments regarding the care to which the Fair Health has been proceeded to design this program with the needs of researchers in mind, trying to ensure that the data are going to be assembled, cleaned, and then provided to researchers in a usable format. And again, thinking of the needs of the researchers, we recognize that quite a few questions have been rolling in. We see people have been entering them into the Q&A portion of the website, and we'll remind you that we will be addressing those at the end of the speakers portion of this webinar, and those that are not addressed will be following up and trying to do our best to make sure answers are available. So in all of our scientific advisory board discussions about the NPIC database, we've been trying to balance the need for program integrity, accountability, and the interest to have a nimble, accessible, streamlined application process. We've also been focusing on achieving greater clarity about the types of research questions that can and can't be addressed with the Fair Health data. As you know, the data collection offered by Fair Health includes cost information about thousands of CPT codes in all geographic sections of the country. So these data can be used for various types of studies. For instance, a researcher could aggregate costs from around the country, within a state, or down to a particular geozip. Some researchers might be interested in uncovering regional variations in costs across the country with respect to a specific procedure. You could consider regional variation in costs. The NPIC data could be cross-referenced with quality data from another data source to assess the relation between cost and quality to try to get at this ever-elusive concept of value. Cost variation could also be used, as mentioned by Scott earlier, to help inform analyses regarding the impact of out-of-network utilization on cost. Now, with respect to utilization, the NPIC data provide a sweeping window into how and how often care is assessed. Now, with over 125 million beneficiaries in the database, researchers offered a unique perspective on the patterns of utilization at the national level. So, for example, procedure utilization data could reflect access to various preventive and diagnostic procedures, such as colonoscopy. One could juxtapose colonoscopy utilization data with other resources to assess the relation between colonoscopy use and cancer incidence or outcomes. Likewise, one could see variation in utilization with respect to the frequency of emergency room visits in certain geographic areas to see if ER utilization is associated with poor access or other poor health outcomes, again by linking the Fair Health data with other data sources. Similarly, given that Fair Health data date back as far as 2002 in some instances, it could be possible to see or to assess changes in clinical modalities over time, to assess the adoption of new technologies, or to assess the effect of a regulation or piece of legislation on utilization. One example of that we're particularly concerned about here in Connecticut is the recent passage of a breast density information state mandate. The Connecticut State Legislature about 1 year ago passed a law requiring that all women with dense breasts be informed that mammography is less sensitive with increased breast density, and because of that because of that reduced sensitivity, they should be speaking with their physicians about ordering an MRI or an ultrasound test. There's little data to support this, and there are concerns that this state legislation could lead to increased use of these additional modalities, and that's a great type of question that could be addressed with Fair Health data. Other questions can include in the cardiology arena. I thought it would be helpful to highlight some particular studies. For instance, a researcher could explore a coronary artery bypass graft, or a CABG, and such a study could uncover the average cost of the CABG procedure across the country or by regions. One could also evaluate geographic differences in utilizations of CABG and determine whether there's a different approach to revascularization of the coronary arteries by region or by state. For instance, one could assess the ratio of CABG versus other less invasive procedures such as cardiac stents. This data could also be juxtaposed or merged with other data sources that evaluate quality or outcome measures. Now, as I mentioned, with this issue of breast cancer screening, the Fair Health personnel have been kind enough to generate some very preliminary data for us. So here we see 3 states, Connecticut, Illinois, and Texas, and these are very crude preliminary data that, just for really illustrative purposes. But we looked at the difference in breast cancer screening methods by state in the year 2010. And what we found on the left side here you see 3.9% of the procedures, of the breast screening procedures, were MRIs. 85% were digital mammograms. Only 11% were film mammograms, which is the older modality, much less expensive. In Illinois, the center group, there's far fewer MRI use than there is in Connecticut, roughly half as low of a proportion. And similarly, there's less digital mammography than there is in Connecticut. And you see Texas lies somewhere in the middle. So here, this is a nice example of how we can start to get a snapshot of interstate differences, which could, in a more robust analysis, be used to really understand the potential impact of state laws on screening and overall test utilization. Another interesting type of study that could be assessed using NPIC data would involve prostate cancer treatment. There are newer and very expensive surgical and radiation modalities for prostate cancer that have been disseminating into the marketplace. It would be very interesting to look at these data to assess cost and utilization differences, for instance, between open and robotic prostatectomy and between these different radiation modalities. One could look at regional differences in the use of these modalities to see whether there are certain states or regions where patients are more apt to obtain specific treatments. There have been myriad studies doing this type of analysis with Medicare, but really very little as far as the private insured younger population. So these are just a few examples, and as you can see, there are numerous types of studies that can be done using the Fair Health data. It will be very interesting to see the applications for the database that are coming in from researchers in the coming months. I know that Fair Health will be tracking questions about the data, the application process, and the actual data usage, and then we will, as part of the Scientific Advisory Board, be using that information to help refine and develop custom cuts of the data as appropriate to help inform the array of services that we offer to researchers. Now with that, I turn over the presentation back to Robin, who will discuss the application process in greater detail.
Thank you, Cary. I would like to take these final moments of the presentation to describe in a bit more detail the particulars of the application process. Researchers interested in learning more about our research program now can go to our website at fairhealth.org to find a short form that can establish a communication link with Fair Health. Once we receive such an expression of interest, a Fair Health representative will be back to you to answer all questions. When we launch officially in July, those researchers who want to proceed more formally with the application process can complete an application form which provides the key details that would inform the licensing agreement, such as data sought, term of license, research purposes underlying requests, timing issues, and so forth. Once we receive and evaluate that detailed application, we will contact the applicant to finalize pricing and fulfillment details. Once those details are finalized, the researcher can download and complete the streamlined data use and access agreement. We will then process the order within a short turnaround time that could be expedited if necessary, depending on research needs. We will have Fair Health personnel, both technical and statistical personnel, as well as service representatives available to assist you at every step of the process. Our streamlined, clear documents and FAQs should smooth that process and render it extremely easy to interface with our research program. With that, I will conclude the formal presentation. But before I turn the podium back to Jane, I wanted to note that we will be making a presentation at the Academy Health Conference on June 24th. We will also be hosting an innovation station over the 3-day conference. If you have any interest in meeting with our team while we are in Orlando, please let us know. I hope you will find your way to the innovation station, where we will be offering a slideshow sampling the data and other key aspects of the program.